Well, here's the thing. You have employers which are highly fragmented. There's over 100,000 self-funded employers in the United States. That's a lot of cats to herd. Conversely, there's a lot less hospitals. One of the large employers here today, Fortune 50 employer, knowing that cell and gene therapies is a huge area and is only getting bigger, has leaned in and said, we're going to create a strategy where we give our employees access to those services. We make them less expensive, more affordable, more accessible, reduce some of the financial toxicity associated with those conditions. But the quid pro quo is you got to go to the right place that's going to do it with the right titration, with the right approach, with the right protocols.
Where are the areas that you are seeing that $1 million bill just for a single member or their dependent and a single condition in a single year?
This is Second Opinion. I'm Christina Farr.
I'm Ash News. And I'm Luba Greenwood.
Welcome to the pod, where each week we navigate what's really going on in healthcare through strikingly candid conversations with the entrepreneurs and investors leading the charge. As your co-hosts, we promise to bring the perspective of a former journalist and investor, a doctor, a lawyer, immersed in the future of medicine with life sciences and digital health.
And we're here to sift the signal from the noise in all of these conversations. Thanks for joining us. Let's dive in.
Hi, everyone. I'm your host, Chrissy Farr, and we have a very special episode today. I'm recording live here from Aspen, where I've been invited to join a summit where some of the biggest employers in the country have come together to talk about the problem of rising healthcare costs. This has become a very big problem, particularly in 2025, and it's all down to things like rising rates of cancer, the growing prevalence of GLP-1s, which are really expensive medications people are increasingly taking both for things like diabetes and weight loss, and of course these new cell and gene therapies. I've been talking to jumbo employers who have been facing costs in a single year of hundreds of millions more dollars in light of this. And yet they still are under the hook to maintain high quality healthcare because the talent market is still really hot. You don't want to lose some of your great people to another company. And so one of the ways that you do that is to provide really fantastic health insurance and a full suite of benefits. So we've had some really candid conversations this week on everything from single payer to why employers are still covering healthcare at a time when so many people are losing jobs and leaving jobs every couple of years, or maybe don't have an employer at all. And then what kind of system would replace that? So I asked all these questions and more to two guests that agreed to join me today. The first is John Zutter. He's the CEO of Lantern, a company that works with these big employers on really high cost items like surgeries and oncology to help direct members, that's the employees, to sites of care and to particular providers that are incredibly high quality. And in doing so, they bring down cost. And then I'm also joined by Matt Harmon, a longtime benefits executive who's worked at Fortune 100 companies and has really seen through multiple decades the evolution of employment and healthcare. Let's dive in. So I'm here with Lantern. We just had a big summit where some of the biggest employers in the country talked about everything that was keeping them up at night in 2025 and just various concerns about cost and proliferation of point solutions and so many other issues. So I'm here with the CEO of Lantern, and I'm going to kick things off with a question to him. Just recapping the event, it's been a crazy few days up here in Aspen. What have been some of your big takeaways?
Yeah, so we host this event for two reasons, right? As a specialty care platform, representing some of the larger employers in the United States, we want to get their feedback about what's important to them and how can we improve. And then second is kind of what's more broadly topics that they're facing either today or they anticipate to face tomorrow. And so we always get a lot of great learnings, both introspectively and more broadly. I think probably the biggest takeaway from this group is an increasing focus on the biggest ticket items and a requirement to really dig into where are the dollars and cents being allocated today, where are they growing fast because trends getting out of control. And so I think specialty care happens to be, the epicenter of most of that with respect to cell and gene therapies, infusions, cancer treatments, large surgeries, et cetera. And so hearing how employers are thinking about each of those things has been reinforcing of what we focus on every day.
So, Matt, you've been involved on the benefit side with a lot of different Fortune 100 companies over the course of your career, and you've seen so much change. So, one of the questions I have for you, and just so many others that I've spoken to at the summit, have been really on this $1 million question. So it was uncommon, from what I have understood from this crowd, that you would see anything costing $1 million or more for a single condition in a single year. But now you see it a fair bit. It's become pretty common. So where are the areas that you are seeing that $1 million bill just for a single member or their dependent and a single condition in a single year?
Yeah, so medicine has improved significantly with technology, with studies, and also cost has also gone up. So we can do a lot more, but it also costs a lot more. $1 million claim used to be considered a super high cost claim. Maybe it was a NICU baby. Maybe it was a particular specialty surgery related to brain cancer. Maybe it was an event that went bad that had to be rectified. Now they're quite common, where you could see $1 million claim. And when you have a population that might be hundreds of thousands of employees, the likelihood of you having multiple of those types of incidents is quite high. And for smaller employees, that could really break the bank. Cell and gene therapies that John mentioned earlier, these are highly customized treatment programs that are specialized and cost a significant amount of money. Some of these might be in not just the $1 million range, they could be in the tens of millions of dollars of range. So it is incumbent to really understand the marketplace, the regulation that's out there, what's available in terms of care, and how do you mitigate it so that you can take care of your population the way they deserve to be taken care of, but at the most efficient and effective way with the highest quality. And I'm going to underscore quality. And John, you mentioned, what if it goes wrong? Well, if you have a surgery that's performed at a less than 1% complication rate in a specialized platform like Lantern versus one that's 12 to 13%, you're much more likely to put that patient back through a terrible episode of having to have a secondary or a tertiary surgery, not to mention the cost that comes along with it. So for people like us that come to these wonderful things, it's getting together with our peers who have the same problem but have the same passion for our people and helping them in healthcare. And that was the most delightful thing I got out of the summit here in Aspen, is that we're all here to solve the same problem. Healthcare is broken. It's dysfunctional, it's disjointed. People don't understand it, especially when you talk about an hourly employee. And so giving them that guidance and that ability to get the care they need to solve their problem is at top of mind.
Okay, so I'm going to just dig in there, because you said sometimes we're talking about $10 million for a single patient in a single year for, and let's use one of these cell and gene therapies. Now, if I'm Microsoft or I'm OpenAI, I can probably afford that, right? That wouldn't break me. But a lot of these smaller employers, how in the world could they afford a price point like that? And is that going to get us to a less equitable healthcare system, where if you work at a big, large jumbo employer, maybe they pay for it. And if you don't, sorry, maybe you don't get that high priced treatment.
So I'll answer with Occam's razor. The simplest response is usually the right, but they can't afford it. It could bankrupt the company. They may have stop loss insurance where it gets covered for that one incident, but then is not covered thereafter. So it is really completely unsustainable and is really something that has to be addressed. It's painful at a Microsoft, but can be managed. It could be catastrophic at a smaller employer.
Well, and I think that creates a couple of things. First is the threshold to become self-funded versus fully insured has been moving down. And I think we're at an inflection point where it's going to go back up. And so it's not uncommon at all over the last handful of years to see. So self-funded is when the employer is taking the financial risk associated with the medical events of their population. Fully insured is when your the health plan itself is providing insurance and they're taking that risk. So you pay premiums in a fully insured model, and the insurer takes that risk. In a self-funded, while the employee sees premiums in their paycheck, the employer is actually paying all the claims. So historically, you would say above 1,000 employees, you're probably self-funded. Below 1,000, it's a question. And over the last 5 years, that's been moving down towards, call it 300, where people have really thought about self-funding.
And then a lot of that is because of just the flexibility it gives you.
You have flexibility where you can put in other solutions, you can customize things, you can start tailoring your approach to your specific needs. Now, when you look at cell and gene therapies as an example, with a couple dozen approved today, a couple thousand in the pipeline, and the average cost being a couple $1,000,000 each, sometimes much higher, that just means you can't afford those things, especially as a smaller employer, which might push that threshold for self-funding just to be higher. But Matt made a point earlier about the change in medicine and the change in delivery approaches. Years ago, the $1 million event was you had a complex surgery that went wrong and the person's in the hospital for a long period of time, a NICU event, etc. Now it's more common chronic conditions or genetic conditions where the amazing and the hopeful part is that there are solutions that are curative and or substantially reduce those symptoms and improve quality of life. But until they get to a degree of scale, from a supply chain perspective, from a pricing perspective, they're just downright unaffordable. And so I think part of that is risk spreading. That's smaller employers going into fully insured models where it gets spread across a bigger population.
Or collaboratives where they can share the risk with other employers.
And then for large employers who are on the bleeding edge, it's about putting in place very specific and customized solutions. We've got an employer here today who, on that bleeding edge, is put in place a COE network that we're supporting. Center of excellence, meaning a narrow network of those that are hyper-qualified for a particular
Your
set of
employer
services.
tells you go see this specific doctor because that's a better doctor. But
And one of the large employers here today, Fortune 50 employer, knowing that cell and gene therapies is a huge area and is only getting bigger, has leaned in and said, we're going to create a strategy where we give our employees access to those services. We make them less expensive, more affordable, more accessible, reduce some of the financial toxicity associated with those conditions. But the quid pro quo is you got to go to the right place that's going to do it with the right titration, with the right approach, with the right protocols. So I think the large employers have the luxury and they have the resources to really explore what are the ways to solve the problem tomorrow. And the smaller employers actually either draft off that or they have to kind of group together to get some scale.
yeah, well, like you said, go back to the health plan to figure it out, which is kind of the old model, that used to be what was more common.
Let me give you the practical answer from a small employer. They exclude coverage. They don't have a choice. The financial toxicity that John mentioned is two parts. It's one for the patient and it's one for the employer. So a lot of employers without FDA evidence on some of these very high cost medications or the ability or staff to even evaluate that are simply saying we're not covering it until we know more. So that's the practical answer. Then there's three other choices that John's already articulated about what they could do if they did want to cover these life-saving yet highly expensive procedures or processes.
Hey everyone, we'll get right back to the conversation after a word from our sponsors.
This show is sponsored by Midi Health. There are certain things that come with age: wisdom, experience, and knowledge, to name just a few. But if you're a woman over 40, it can also bring some less desirable things: hot flashes, insomnia, brain fog, moodiness, and weight gain, all symptoms of menopause and perimenopause. Yes, hormonal transition is a fact of life, but that doesn't mean you should have to accept its symptoms as just another part of aging. The experts at Midi Health understand what you're going through and know how to help. Midi Health is the only virtual care clinic for women navigating midlife hormonal transition. They support you with safe, effective, FDA-approved medications, as well as supplements, lifestyle coaching, and preventative health guidance. What's more, all their services are covered by insurance, and they're conveniently accessible through telehealth visits and 24/7 messaging. If you're over 40, use all that wisdom you've gained over the years and visit Midi Health. You deserve to feel great. Book your virtual visit today at joinmidi.com. That's joinmidi.com. This is a confidential summit, so I don't want to name any names, but I want to take us up a level a little bit for the audience. Who here can tell me what percentage of people in the United States get their healthcare through an employer today?
It's about 60% get it through their employer. Large self-funded employers are by far the biggest providers of benefits to Americans, substantially larger than the government. When you combine Medicare and TRICARE, they're nowhere close to the self-funded market. So the self-funded market, there's different statistics, but generally they're between 150 and 200 million Americans get it through that stage.
We're talking about crazy numbers. We're talking about, this today is where most people in this country get their healthcare. At this very summit, and again, not naming names, a debate broke out amongst employers saying, why is this our problem? I mean, why in other countries around the world, employers are not providing healthcare? It doesn't make sense at a time when, it's not all employers, but some employers are seeing people stick around for like 3 years and then move on for another job. And so they've got no real skin in the game around long-term health outcomes. And they're facing like these crushing rising costs year after year. I think you had some employers say just last year alone, it went up over $100 million. I mean, they're seeing enormous increases in trend. So why is it their problem? And do you see this changing anytime soon?
I'll give you a different statistic that's more on a relative basis. We've got a new client who, again, nameless, but a Fortune 100 company with a substantial workforce distributed around the United States saw their healthcare spend go up by 18% this year. 18%. It's the second largest line item on their finances.
About like 100 million.
Yes, enormous sums of money. And so you asked the question, or you reiterated the debate from the session in terms of why is this employers' problems? Well, a couple of things there. First, most other advanced nations around the world have totally different structures in terms of government-provided healthcare, socialized medicine, things of that nature. We don't here. I think why we don't and whether we should or shouldn't is probably a conversation for smarter people than me, but it's a very entrenched system. I don't see it changing anytime soon. I think the bigger response to that is one that was actually mentioned yesterday, which is if the employers don't, who will? Right? At the end of the day, since they are the ones who are writing the check for the majority of dollars of healthcare in the United States, they have the biggest interest. They have the responsibility to take care of their people, and they, in aggregate, represent the largest buying block. They also, because they are self-funded, have the most flexibility to think about different tactics and levers to be able to effectuate change, and they have control over their destiny. So if they're not going to, who can?
But then at the same time, I've sort of been surprised as somebody who's had a career in media and investing, why haven't they rebelled and spoken out more? Because, there are so many things to driving cost up. And I think you mentioned the levers. They do have a platform, and it does not seem like they've been using it, outside of a few efforts that have failed, like the whole Amazon JP Morgan initiative that we all remember. I think it was called Haven, did not succeed. But aside from that, I can't think of too many times where employers just raised their hand and said, something here is very, very wrong. And there is no reason why this intervention should cost this much. And we need to band together as an industry to create a lot more transparency.
I would push back and say they do, and they are, and there are a variety of forums that do that. So there's the Health Transformation Alliance, which is 55 large companies representing 5-6 million employees. There's the Business Group on Health that has both local chapters but consolidates up to a national forum and tries to advocate on behalf of large employers.
I mean, I'm with you on all that. I could draw up this more, but where's the op-ed in the Wall Street Journal?
Well, here's the thing. You have employers which are highly fragmented. There's over 100,000 self-funded employers in the United States. That's a lot of cats to herd. Conversely, there's a lot less hospitals. There's a lot more consolidation in them. 10% of physicians in the United States work for Optum, right? That means that you have concentrated voices that can then go in and make their voice heard, and those aren't always aligned with the employer. So the fragmentation of the employer market, even those large employers, they have a huge voice, but they're still a minority relative to self-funded employers at large. And so getting all of them together we talked about it today. One employer had 35% annual turnover, and the other one had average tenure of an employee of 17 years. Those are very different use cases. One has 80% of their population in 4 cities, and one's in 5,000 different towns around the country. Very different problem sets. And so the fragmentation of the problem, the fragmentation of the voices contrasted with the other stakeholders in healthcare, which is care delivery, while it's Fragmented in many ways, it's much more concentrated. Insurers, much more concentrated. Big pharma, much more concentrated. And so easier for them to deliver their voice and their message compared to the employer.
So I'm going to pick on you, Matt. So we talked about GLP-1s. That was like a huge topic of the summit, mostly because members want access to GLP-1s. I think that came off loud and clear. But we definitely also heard statistics around, it takes some time before you start to see real ROI from a patient being on a GLP-1. And then you also see these really high rates of patients dropping off of the drugs. You see challenges with just like the lifestyle and behavior change that needs to come with the drug. And that made me think, when you just said, John, there are employers here where people don't last more than a year or two, then what's the reason for them to get behind, say, an expensive GLP-1 program when it's going to take 10 to 15 years before they see real cost savings associated with a drug like that? Or do you just say yes because your members want it?
Your members want it. And I don't think there's been a time in modern history coming out of the pandemic that it's been harder to attract and retain a workforce. You've also got this huge marketing arm that has got these GLP-1s on the megaphone, and they're talking much more about the benefits than some of the drawbacks. So there is a heightened demand for these. They're being told by their doctors that you don't have a choice, you need to do this, or you could have a catastrophic situation. And it's not just weight loss. Type 2 diabetes is the number one indication for this. And now other providers like Novo Nordisk is getting MACE indications for cardiovascular sleep apnea. So the proliferation of the use cases for this is very high, and workforces want this. And some are seeing good results. It's so new that if you're doing something that's happened 6 months ago and people drop off at 6 months, you don't have enough medical data, to your point, to justify what that ROI is. So I think in the early stages, some employers are only covering it on the diabetes side, not for weight loss, right? Some are covering both, and some are considering what lanes they would be willing to be in depending on the pressure that's coming from their workforces and their populations. Also, and can't be understated, because of the quote unquote shortage, there's been a proliferation of compounding pharmacies that are creating some of these at a fraction of the cost. There's direct programs. So there's even beyond what employers are seeing. They don't see the data for these third-party resellers. They don't see the data for a Lilly direct program that's going direct to the manufacturer. In some cases, the cards that are being provided by those manufacturers are subsidizing those costs to invite people in to utilize their product in hopes that they will continue on by seeing those results. So it's going to continue to evolve in this conversation. And I think it's not going away anytime soon.
All right. So last question for the two of you. America, I did not grow up here, as you may have noticed, but I've definitely detected a strong sense that people care a lot about freedom in this country, and they care a lot about choice, and they don't want to be told what to do. And so as an employer, how do you balance that with, you want people to be healthy for all the reasons that are obvious. You want them to eat well, you want them to exercise, but at the same time, how prescriptive can you be with these populations? And how much can you say, well, you can have access to that really expensive drug, but you must also do all of these other things to qualify, such as, the food and the lifestyle components that are so important. And how do you think about that? Being able to sort of balance the two things, because it's unlikely to work without the other.
So I'll start historically first. Employers for years have rolled out programs like this. It's factual that behavior change amongst those populations is almost nil. Very small engagement in some of these programs, okay? So it hasn't affected change, and therefore these other different scenarios have come out. There are 100 work streams, whether it be nutritional ketosis, whether it be type 2 diabetes reversal, that are non-medication driven, and those have gotten very small overall results. So what's happening now is some employers are saying you do have to go through either a prior authorization or step therapy or both to prove that you've tried those less invasive, less expensive, more clinically appropriate routes first. And if those didn't work, then and only then will we approve these types of measures.
And how do members respond to that? That they have to try all these other things. And meanwhile, we've been getting all this marketing saying it's this magic pill, which kind of fear.
A ton of friction. And so how do you diffuse that friction is a lot of times people just want to know what the process is. I think they do understand the high expense of it. And so many are willing to do it. The ones that are not willing to go through that process that have the means to are going to some of these compounding options where they feel comfortable saying, I want it, I'm willing to pay for it, I'm going to go do it on my own. For those at the employer level, most are generally willing to navigate what they have to get the treatment. Otherwise, if there's a more clinically appropriate avenue, they'll try that first. And if that works, that's great. They don't have to go beyond that. But in general, and again, this is in general, because this is such a highly publicized miracle pill, people are generally willing to jump through the hoops that they have to. And hoops is nothing new to healthcare, by the way, in this country. Almost every other procedure or something that has got a high expense and has safety concerns and some of the other things that clinicians have to look at beyond cost, they go through these processes in order to check those boxes before they can move on to that more basic treatment.
You were talking largely about GLP-1s, but maybe kind of playing off your last point, broadening the aperture, there's a cultural dynamic here that's at play too, which is, does the employer want to be directive with their care or do they not? And for many employers, that's a hard line they're not going to cross because it's not part of their culture to tell people what they can, can't do, et cetera. And so in those contexts, there tends to be more of a carrot-based incentive model where people say, I will give you this to make this better decision or this alternative decision. What we've seen as a substantial trend over the last number of years, though, is in narrow lanes of healthcare, the higher cost things, the higher risk things, whether that's in surgery, whether that's in infusions, whether that's in cell and gene therapies, whether that's in GLP-1s, saying, we are going to cover it, but you're going to have to go to certain places that are going to meet a quality standard, that are going to meet an outcome standard, that are going to meet a cost affordability standard. And so we've seen an increasing rise in that. And when you take a step back and say...
It's like the rise of the caveat.
Yeah. And so, and I think just to put some context around that, healthcare spend is incredibly concentrated, right? Which is why your $1 million question, so to speak, is a good one. 1% of members tend to be about a third of the costs. 5% of members are about 60, 10% of members tend to be about 85. And so when you have that hyper concentration, the employer can choose very narrow swim lanes and say, hey, for certain large musculoskeletal procedures, we're going to require you to use this panel of providers that meet a high quality, high cost standard or high affordability standard. For these GLP-1s, we're going to require you to go through this process that's going to be focused on quality and affordability and access. And so you can deploy some of those strategies while not creating as much noise for the broader population because it is so incredibly concentrated.
Then there will be those who say, well, I don't want that. I'm just going to go buy it. But there's nothing you can do about that as an employer. But they're making a choice for themselves. That makes sense. Well, fantastic. I feel like we got into a lot of very important themes in this discussion. More to come. I hope you both will come back and maybe share some thoughts next year.
Sounds good.